Yes, I would like to talk about estimating respiratory muscle effort. Why would we want to do it? How can we do it? And what are the specific targets? So these are my disclosures. And right here you see the diaphragm. The diaphragm is a fantastic muscle. It's a dome-shaped muscle which is positioned between the thoracic cage and the abdomen. It's only 2 or 3 millimeters in thickness in healthy adults. And once it contracts, the top of the dome of the diaphragm moves downward, generating a negative pressure in the thoracic cage, allowing air to flow in from the atmosphere into the lung. When the load imposed on the diaphragm is increased, additional respiratory muscles may be recruited, including accessory inspiratory muscles, scalene, sternocleidomastoid muscle, and when the load is further increased, expiratory muscles might be recruited, including the abdominal wall muscles. The maximum inspiratory pressure that the muscles can generate upon a maneuver like this is close to 100 centimeters of water. But for tidal breathing, we only need a pressure of, say, 5 centimeters of water. As you're sitting here in the room, the diaphragm, the respiratory muscles generate a pressure of 5 to 6 centimeters of water. So it's a huge reserve capacity. Nevertheless, our patients, our ICU patients, may run into problems, as has nicely shown by the study by Chabet. After 3-4 days of mechanical ventilation, pressure generating capacity of the diaphragm might be decreased by approximately 25%. And we all know that respiratory muscle weakness is associated with adverse clinical outcome, including prolonged mechanical ventilation, increased risk of ICU readmission, and perhaps even mortality. Yesterday in another talk, I discussed that one of the causes for respiratory muscle weakness in ICU patients is either ventilator over-assistance or under-assistance. With ventilator over-assistance, the diaphragm is completely inactive. And this may result in disuse atrophy. It's the same thing as would happen if your arm is in a cast. If you don't use the muscle, you're going to lose it. But on the other hand, ventilator under-assistance, resulting in high breathing effort, has been shown to result in injury in the muscle and inflammation, which may also result in weakness. And therefore, for most patients, it seems appropriate to target more or less physiological breathing effort. But if you want to know what a physiological breathing effort is, we have to monitor it. And right now, I think there's 3 different ways you can actually monitor breathing effort. I want to review them briefly. Yesterday, we already discussed in more detail the esophageal catheter. The esophageal catheter can be used to monitor changes in pressure in the thorax during breathing. And this actually reflects changes in pleural pressure. Just can be seen here, as you're sitting here in this room. During inspiration, the red line, the pressure in the thorax decreases, reflecting respiratory muscle activity. And that basically can be done in almost every ICU. What you actually need is an esophageal balloon. You can buy it. It costs about 20–30 euros. You need a pressure transducer. What we use in clinical care is just a disposable pressure transducer you would use for arterial blood pressure measurement, and you connect it to your ICU monitor. So right here, this is your arterial blood pressure, and this is the change in esophageal pressure in a patient on pressure support. So as you can see here, with every inspiration, there is a drop in esophageal pressure. In this case, 7 millimeters of mercury, which corresponds to 9.5 centimeters of water. And this seems to be more or less a physiological breathing effort. I mean, if this would have been like 25 centimeters of water, then it would be probably too high of a breathing effort for this patient. And on the other hand, if it would be 0 or 0.5 centimeters of water, that would be probably ventilator over assist. The esophageal balloon also allows you to do more complex analysis. For instance, the pressure time product, which is the time integral of pressure during the inspiration and the work of breathing. We discussed that more extensively yesterday, and I don't want to do it again, but if you want to review it, it's in these two great papers published by the Blood Working Group in the Blue Journal and in Intensive Care Medicine more recently. So I think the esophageal balloon is an excellent tool and basically the gold standard to monitor breathing activity in our patients. It's available, it's at relatively low cost, and the nice thing is the changes in esophageal pressure are quite intuitive. You know when it's too high or too low. But it requires some expertise, as pointed out in these papers. So second, and interestingly, diaphragm EMG. There's two different techniques, surface EMG, that I want to review first. So right here, you can use surface electrodes to track basically activity of any muscle that's close to the skin, close to the body surface. And right here, this is activity of the sternocleidomastoid muscle in a patient on pressure support, and there's a nice increase in activity during each inspiration. And we have demonstrated, for instance, this is in the scalene muscle, that changing the level of inspiratory support, so reducing the level of support, increases activity of the muscle. The problem though is, it's not really useful to quantify breathing effort. You can see there's a change with changing in inspiratory support, but it doesn't give you a value that tells you if the effort by the muscles is too high or too low. There's a lot of practical issues, there's crosstalk with other muscles, so I don't think this is ready for use in clinical care actually. This is perhaps more interesting right now, and this is the diaphragm EMG acquisition through a nasogastric feeding tube. And this is actually the tube that's used for NAVA ventilation. It has like 9 electrodes right here at the level of the diaphragm that acquires the EMG signal of the diaphragm, and after filtering shows it right here on your ventilator screen. And it was designed to drive the ventilator in the NAVA mode. But the nice thing is actually that you can visualize the EMG signal in any mode. Pressure support, assist control, or even when the patient is disconnected from the ventilator. And as shown right here, so this is one patient at different levels of assist, at 0.6 level of NAVA and 4, with a good pressure support as well. But I actually want to demonstrate you that the amplitude of the signals, the videos are a bit slow right here, the amplitude of the signal depends on the amount of assist by the ventilator. The more assist the ventilator provides, the lower the respiratory effort by the patient, and therefore the lower the amplitude of the signal. And a nice study by Bellani has actually shown that there is a good and a linear correlation between the amplitude of the electrical activity of the diaphragm and the pressure generated by the diaphragm. The problem is, though, that this relationship differs from patient to patient. So, for instance, if you have an amplitude of 10 microvolt, in one patient that corresponds to a pressure of 3 centimeters of water, and in another patient, 9 centimeters of water. So it's not really helpful in exactly estimating the work of breathing. And the group of Bellani and our own group are now working on a way to convert this electrical activity in centimeters of water, but it's not completely clear now how to do that. Nevertheless, it's still helpful. Look at this patient that was in our ICU some time ago, patient with COPD, weaning from the ventilator, 8 of pressure support, 8 of PEEP. And if the video wants to start, it shows right here, so pressure, flow, electrical activity. Now there's some problems with the video, but as you can see here, there's no activity of the diaphragm at all. So despite the fact that the level of support is relatively low, there's no activity of the diaphragm at all. And the only thing so right here is the video, so you won't see any activity of the diaphragm at rate of pressure support. And what I'll do right now, the only thing I did is reduce the level of inspiratory support to 4, and there is activity of the diaphragm. So even though it doesn't allow you exact quantification of the effort, the signal will tell you that this patient at 8 of pressure support was in over-assist. So I think diaphragm EMG is helpful, it's available, it's pretty easy to use in clinical practice, but it's not really suitable today to exactly quantify your breathing effort. And ultrasound is becoming more and more popular. In particular, when using the linear probe placed in the mid-axillary line, you can track, right here, the thickness of the diaphragm. And as with any other muscle, when the muscle contracts, it will thicken. And you can see that right here in the end node. And from that, we can calculate the thickening fraction. The higher the thickening fraction, the more force a muscle will generate. So this looks exciting, and it's becoming more and more and more popular. But there is a warning. This is nice data by Ruben Gallagher right here. So this is the thickening fraction as assessed with the ultrasound, and this is the transdiaphragmatic pressure. And as you can see right here, if we take, for example, a thickening fraction of 100%, the pressure that's generated by the diaphragm can be anywhere between, well, say 10 centimeters of water and close to 100 centimeters of water. So it's not really quantitative at the moment, and I'm very sure that in the future it will improve, but at this time we have to be careful to say whether there is over-assist with the ultrasound. Cardiologists already use more sophisticated techniques for ultrasound, and one is speckle tracking. And speckle tracking is a rather sophisticated way of performing ultrasound, but what it does is looking at so-called speckles, artifacts in the muscle. And if these artifacts move together, it is a way of assessing effort. And we have recently shown that this is in healthy subjects, so I'm not sure how this is in ICU patients. We have recently shown that there is a reasonable correlation between the strain, so the movement of these speckles, and transdiaphragmatic pressure in healthy subjects with incremental loading. So then the difficult question is, if you are using a monitoring technique, what should you aim for? Well, I think the easiest would be using the esophageal catheter. The esophageal balloon, I would say for most patients, perhaps not the sickest patients, but for the most patients, a change in esophageal pressure somewhere between 53 and 15 centimeters of water would be within the physiological range. Electrical activity of the diaphragm, well, at least it should be higher than 5 microvolts in amplitude. And the experience now from thousands and thousands of patients is that usually EDI, the amplitude should be below 20 microvolts. And the thickening fraction, as I pointed out, is a bit more complicated, but at least you want some activity of the muscle. Well, you could say he has a nice story about monitoring activity of the diaphragm, but I didn't see any evidence at all. Well, that's true. I mean, I think it's more or less based on physiological principles. If you're not using a muscle, you're going to lose it, and if the activity is way too high, you get injury and dysfunction as well. And remember, another monitoring tool you're using in your ICU, the arterial catheter, doesn't have any evidence at all that it improves outcome. So just as a comparison. The other thing is, you still can get into the New England Journal of Medicine by discussing which blood pressure targets you should aim for in septic shock. So undoubtedly in the future, we have to find better ways, better targets for pressure measurements, for pressure targets of the diaphragm. But for now, I guess, a more or less physiological aim would be reasonable. So to conclude, there's a good physiological rationale to track activity of respiratory muscles in ICU patients. The esophageal balloon is still the state-of-the-art technique, and we should aim to prevent disuse atrophy and very high breathing effort. Thank you.